This week on the Core Ultrasound Podcast, we have it's like a part two of the interview I had with Mike Prats last week on some new ways to teach in ultrasound education. And we talked about AI, we talked about kind of distance learning and how to do image review of scans virtually. Now, there is actually a part two, and I'm showing you that today, and it is with Ben Smith. Ben Smith was fortunate enough to be available, and we asked him to come on, and we had a great discussion specifically on AI and some of the limitations, some of the wants, some of the asks for AI, and the potential power of AI in medical education of bedside ultrasound. Check it out. Ben, you haven't been on the podcast in a while. I'm so happy to have you. Ben is a full professor at the University of Tennessee at Chattanooga, interim chair of the department. What's that?
I just had breakfast. That's what makes me... I wasn't an associate this morning, but then I had breakfast and now
he's full.
And then you became full professor, right?
Yeah. Tough.
Now you are interim chair of the department. Is that correct? I know that's a recent position. Yep. Congratulations. And also Ben, 13 years ago, Ben was my first attending friend when I was a resident. We really nerded out on ultrasound stuff. We learned a lot. I learned so much from you. And then I went and spread my wings a little bit and was in Kentucky, but we continue to collaborate. And all of Core Ultrasound is Ben and I. Ben basically does all the back end stuff and I do all the front end stuff. So Ben and I talk every single day. And it's so nice for everybody to see your face, Ben. And thank you for joining Mike and I on this talk randomly. I literally sent Ben Ben sent me a text asking about something. And then I was like, hey, do you want to hop on this call with Mike and I? And here you are.
Yeah, it's an honor to be on here. I never get a chance to see a video of my own face. So it's pretty sweet right now.
We're happy to have you. Me too. Just to catch you up, Ben, we're basically talking about teaching using other tools besides us being there. Mike was talking about some articles that show feasibility where we can, you have pre-hospital where it shows that it finds the diagnosis and it tends to be fairly accurate with respects to the final diagnosis, which that 90%, that first study that you mentioned, Mike, that 90% accuracy with a discharge diagnosis, I bet that number is identical to like the initial emergency department workup, right? To be 90% accurate with the discharge diagnosis, like that's actually really, really good. And then you talked about being used pre-hospital cardiac arrest and how it didn't delay anything, which I think that's important. You want to make sure that you're not causing harm. And then we were talking about one of your projects, and then we went on a break, and here we are.
And Ben, we essentially got as far as we could get, and now we really just need to have an interim chair, full professor's perspective.
Mm-hmm. Yeah. What do you think about like AI in general? Because that's the thing that I wonder about is like having AI firstly tell you how to maneuver the probe, how to get a better view, and then also AI potentially, diagnosing or interpreting the images. I'm going to take a quick pause here and remind you about the courses.coreultrasound.com website. We have all of your ultrasound education needs and desires on there. We have a bunch of courses. We have Castle Fest conferences that we've put together in the past, critical care conference. We have a content creation course, and we have courses specifically designed for residency. So we have primary care fundamentals, which is for internal medicine, and family medicine, and emergency medicine fundamentals, which is more geared towards emergency medicine residents and early learners. We also have a question bank. We have thousands of ultrasound questions on there, and they're really simple. We just basically show you an image and we ask you, what is the pathology? Because that is what I think is missing with a lot of our resident and early learner education, which is that sometimes we don't see certain pathology, and the only way to get better at it is with repetition. Go to courses.coreultrasound.com and learn more. Now, back to the video.
Yeah, I think that as an educational tool, that it has a ton of like potential benefits. And so like I do like the idea of like the virtual guidance, so that like, for instance, if you're trying to get an echo view, it tells you got to slide higher because you're too low on that personal long axis view. Classic mistake. Or, twist your probe because you're foreshortening the LV, for instance, just to put a point on it with the echo guidance. Although I will say that like the past implementations that I have seen, and I don't know the exact company, but and it was a beta, I think that I saw it, but like the guidance that I've seen in the past, it was real sort of jumpy. So it'd tell you one thing and then like the second later it'd tell you how to move the probe a different way. So, but if they were able to make a virtual mentor that could tell you how to move the probe to get a better view, like something that I would do at the bedside, as ultrasound educators, we know that like hands-on teaching is one of the hardest things to learn how to teach like effectively, and the most time-consuming. You have to have boots on the ground to do it. So the incredible opportunity for AI to replace a person who's actually in the department our educator time is very expensive. And so that would be amazing. And then as far as like the interpretation side of things, I think the first space that would be most useful in would probably be the education space, where, for instance, it does auto overreads of images and gives, residents feedback. I think that there wouldn't be a lot of, regulation around that necessarily if this is for educational purposes only. Moving into the realm of actually like having clinically interpreted images that are done in real time using some, AI model. I think that there's that's obviously where things will eventually be going. But with like as a cautionary tale, though, we should be viewing the interpretation, the auto AI interpretation, the same way that we, view a decision rule. So like, what are the ins and what are the outs? And am I applying this decision rule, this AI interpretation correctly? So as educators, I see our jobs transitioning over the next 5 to 10 years into how to teach, residents and faculty to use the AI model in a responsible way. There's this huge right now with AI, it's almost like a buzzword, and people are like, oh, like just they view it as inherently good. And I'm kind of a little bit more on I've seen things go badly, with my own AI projects. And admittedly, I'm an amateur when it comes to like building AI models, but if it's not done with the correct ends, then you're going to get outputs that are incorrect.
Now, Ben, I love that perspective, because what you call amateur is actually like more advanced than most people in our field. So I've learned a lot from you about the process of creating deep learning and everything that goes into that. So I value your perspective on, some of these concerns that we should be aware of going forward, because at its, most simple, all of these things are very similarly taught, right? You're taking some database and trying to train a machine to understand what you're looking for. And because that's going to be finite at some point, like you can train it on a certain number of cases or images or whatever, it's never going to fully be able to replace, like decades of experience, probably. Is that fair to say?
Yeah, that's probably correct. And I would be interested in seeing, if you had enough data, theoretically, it could be as good as the best of us. But it has to be put together in a really like thoughtful way. So I would include in any like AI model that I'm training common mistakes, commonly placed probes, like not only a perfect, Morrison's pouch view, but maybe the same view but flipped, and positives and negatives on those common mistakes. And the inputs have to be done with expert consensus. So like if you're going to interpret, if you have a positive right quadrant view that 10 out of 10 clinicians say are positive, and you've got another one that's just a fat pad, for instance, and 10 out of 10 experts agree that it's a negative. Well, sometimes there's like a middle ground where you're like, like for lack of a better term, would want to clinically correlate. And so like, what do you do with those, and how do you build those into the model? It gets more complicated than just feeding a bunch of data, into the database. Like just the same way it's complicated when we look at images, it's not always black and white. It's shades of gray, if you will.
Nice.
Nice.
Yeah, I wonder what happens with these.
I'll give some snaps to that.
I'm sure that was the first time Ben used that. But what happens in cases where there's
Ben never uses puns.
What if there's just like a really rare pathology? Like, let's say you're doing these echoes, and maybe there's like a necrotic cardiac tumor, and there's like fluid and air in a weird place or something. You know, I could imagine that this algorithm that's trying to guide a learner might either totally miss it or might misinterpret it. Whereas somebody that, even if we've never seen it before, we could figure out, like, that's not normal. That looks weird and concerning, and know that we got to take the next steps. Whereas if someone doesn't know that, it could just be like, well, we couldn't get a good image, or like, hey, just keep trying. I don't know.
Yeah, the AI models will give you like a confidence percentage, which that's a part of using the AI, is to understand not only is giving you what interpretation is giving you, but how do you then weave that into your clinical, gestalt or your clinical workup based off the percentage of accuracy it's giving you. So it may say, a situation like that, it's a pericardial effusion, but I'm only 50% confident. And so it'll give you an actual confidence, which is a useful metric to be able to, use. But yeah, like rare diagnosis, rare things are going to give it images that it may misinterpret for sure. And I think being able to have from AI, industry point of view, they should have some way to reinform and rebuild the model based off these outliers. So I kind of like in an ideal situation, these are models that are shared amongst companies that are, just like drug surveillance, when we're looking at like rare effects of drugs and the post-market analysis, the same thing should happen with AI models. They shouldn't be stagnant. They shouldn't be static. They should be dynamic and rebuilt with new data. So there should be some, if the machine is using a AI model, there should be some way to anonymously upload a clip and say, this is actually amyloidosis or something like that. Something that's rare, relatively rare, that may give you a different looking image. And if we could have this model that is dynamic and a living document almost of rare conditions, then it'll eventually be better than everybody. I mean, and eventually we will be able to rely on it, but there's going to be some growing pains.
That's good insight. I mean, I like it as well, because I was talking to Mike about this before you got on, Ben, and that is that I've been very I don't see the use of any of the AI stuff, because usually I'm there and the AI does stuff and I'm like, that's a little off, and then I tweak it, but we're not always there. And there's going to be more of a need, more learners, more access to ultrasound. And I think this would be a good, even now, let's take it at its most basic, which is helping with getting an adequate view. At that level, I think there honestly is a place in a market for it now, because the whole point is to help people use ultrasound to quickly and accurately figure out what to do with their patients. And I think this is a way to do it. Yeah,
the education side of things seems like pretty low-hanging fruit with not a ton of downside. I feel like that, that is like the easiest thing that AI can do to, quickly get into the ultrasound education market. I think that when you start to move towards AI interpretation of images beyond something like AI auto EF, that seems pretty straightforward. But if you get into things like this is the diagnosis, it gets a little more complex, and then you're starting to get into regulations and FDA approval and stuff like that.
I have a question for both of you. When do you think is the ideal time to incorporate AI into education? So let's say you have these machines, there's AI applications on them, or there's some self-guidance learning applications using AI. Do you think that you should first try to teach them? If you had these learners with you, you would first try to teach them without it till they get up to a certain level, then add on the AI layer? Or do you think because it's here and because these learners are going to have AI probably their whole lives, should we just start integrating it simultaneously as we're teaching the basics? Do
you want to go, Ben, or should I go? You go or I go?
Yeah, I'll go. I mean, I think that this is probably just ego, but I would say that the best thing is for us to be there hands-on teaching first, and then let the AI come in behind us, because I just can't see that a student or learner interacting with the computer is going to be better to start out than someone who is in real time giving them feedback that's useful. And I don't know, I feel like we can, they're going to be more receptive to us than they are to a computer at the beginning.
I agree wholeheartely. I mean, how many people do you think outside of residents that the three of us collectively have taught in the past 10 years, right? And Ben, you were an attending while I was a resident. So let's say the last 13 years for you, right? So 10 years for Mike and I, because we're the same class, just 13 years for Ben, because you're young, like us. You're young like us. Like, how many people have we taught, right? And then I see this all the time where I'll have somebody, when we used to do Castle Fest, right? We'd have somebody like at Castle Fest, this phenomenal conference in Kentucky that Mike and Matt and sometimes other Mike would put together. And this is Malin and Stone, not Prats, because Prats, you were a resident and a fellow like me. But when I took over that conference and when I started teaching it, I would notice that we'd have people that would come in, community rural docs. They were so excited and they're like, I'm going to do this. We would do hands-on with them. They'd be getting the views. They'd be understanding and they'd be super stoked. And then a year later, they didn't do anything that entire year because at their shops, they were the only ones there that did it. And so they didn't have like that guidance. And then it was almost like they didn't use it for a whole year and then we had to like start over. And then I see that sometimes with residents, right? Especially if I'm teaching off-service residents that might not have an established ultrasound program where we'll do our workshop and then I'll see them in the department 8 months later, right? And they can't get a basic echo view. So totally agree with Ben. And I think that the more I talk about it with you guys about this, the more I'm realizing this could be helpful right now to even our residents, because we are not with all of them individually in the department, number one. And number two, when they go to off service, rotations, we're not with them. And this could be helpful in that situation. I think it'd be massively helpful in that situation.
Another place that the AI is like an educator model would actually work really well is in residencies where point of care ultrasound is just very young. And so I think about family medicine and internal medicine. In family medicine, they have actually it's on their RRC guidelines to have, POCUS as part of the curriculum. And yet not many of the programs actually have a champion of ultrasound or even anyone that can do hands-on training with them right now. And so it can bridge that gap while they're still trying to learn. And I will say that, we found the same thing with didactic education too, is that, if you've got the weekend course, the weekend ultrasound course has been not a super successful model because people, they come in, they're real excited, and then, they just don't continue to do it. There really needs to be a longitudinal curriculum. And so, having, access to an online asynchronous platform, and it's somebody who can help mentor them at the bedside or an AI model, that all actually can bridge that gap before, as they're trying to develop their ultrasound champions at their various shops.
This is going to be a shameless self-plug, which is why we have primary care fundamentals. Right, Ben?
Shameless, totally. But that's exactly why we built it, because we knew that this was a need. And that's kind of the two pillars of ultrasound education is the didactics and the hands-on. And you can't have one without the other. But the hands-on is so time-consuming. And we have ultrasound fellowships. We've got fellows help sort of augment the hands-on time. But if you're the only ultrasound educator at your site, or you don't have anybody at all, that's just a super challenging thing to get done.
Yeah, it sounds like I agree with what you both said. And it sounds like, as with many things, kind of a combination approach works well. And so in this case, I feel like you got to get learners up to a certain threshold before they can even really effectively engage with AI or tele-ultrasound supplementation of their education. They got to know the basics, understand probe motions, understand the colors, understand what they're seeing on the screen to some extent. So possibly you start off with some hands-on in-person training, ideally, and then for the purposes of spaced repetition and longitudinal continuing education, there's a big impact that could be made through some of these tele applications.
For sure.
Brilliant. So that was a great discussion, Ben. What a wonderful gift for you to be on the podcast, because when we try to plan this in advance, it never works out. And spontaneity was our ally and our friend today. So good to see you. And Mike, so good to see you and chat with you as well. So Mike, do you have a joke? A dad joke? It's okay if you don't.
I wish I did. I mean, if I'd had more time, I could have definitely prepared one, but not off the top of my head.
Okay. So ChatGPT to the rescue. Are you ready? We're using AI. In conclusion, we're going to use AI to tell us a joke about AI. Are you guys ready? Can you tell me a
That's smart.
dad-style joke regarding AI? Why did the AI go to therapy?
Why?
Because it had deep learning issues.
That's
You're
good.
welcome.
I like that.
Thanks, ChatGPT 4040. So my name is Jalen Avila. Ben Smith, I'm in San Diego. Ben Smith is in Chattanooga, Tennessee. We have Mike Prats out in Columbus, Ohio. That's with a U. Columbus, Ohio. It's a great place. They have a little hockey team, a good hockey team. They got the Blue Jackets. Visit Chattanooga, visit Columbus, visit San Diego. I hope to hear from you soon, and happy scanning.